Evet, hepinize tekrar hoş geldiniz diyorum.
Welcome you all. It was a very tiring day, but thank you very much for being here. I would like to also thank Professor Mustafa Çetin for inviting me and for this very good meeting. Yes, we have struggled with clozophobia and we were able to beat this phobia actually, but then again, if we cannot get the desired response, what are we going to do? What will be our next step if clozapine is not enough? In approximately 60% of the treatment-resistant schizophrenia patients, moving on to clozapine is an effective measure. But what do we do if it's not enough? There is this group of patients who has no response or partial response to clozapine. Then we can augment clozapine. And for some patients, we cannot administer clozapine due to side effects or the patient doesn't accept that, maybe for some other reasons as well. Then what can we do here? Augmentation of clozapine. I will be talking about this augmentation methods, but I will also touch upon this other group where we cannot administer clozapine. When we look at the literature, non-clozapine antipsychotic combinations are tried, especially in the last years. High-dose atypic antipsychotics can be used. There are also studies suggesting that. Augmentation of other antipsychotics can be another issue, but I'm not going to touch upon to that. I will be talking more about the augmentation of clozapine and the use of high-dose atypical antipsychotics and other antipsychotic combinations. I will be basing my judgments and arguments on that. Before we decide to augment this clozapine, we have to first of all review the compliance to treatment, and the clozapine monotherapy should be tried for at least 6 months.
And in centers where it can be measured, the blood levels should be measured and should be shown that it's effective. And if a decision of augmentation is made, then the interactions with the add-on medications should be taken into consideration. If it is used with other psychotropic medications, additional physical health evaluation might be needed. If the whole augmentation process is to be evaluated, there needs to be objective scales, and any augmentation trial should be time limited. And this is generally 3 to 6 months. And if response is insufficient, the add-on agent should be discontinued, and it shouldn't be continued as it is. Clozapine augmentation in schizophrenia patients, and I will be talking about other somatic treatments, and I won't be touching upon psychosocial methods and the other antipsychotics, mood stabilizers, antidepressants, other pharmacological treatments, electroconvulsive therapy, and transcranial magnetic stimulation are the new therapeutic alternatives. Addition of other antipsychotics to clozapine, most numerous studies have been conducted together with risperidone, and in Hacettepe and 9 Eylül universities there was a joint effort which was published in the year 2006. This was a controlled study. This was the second of the controlled studies in this field. In fact, in positive and negative symptoms between placebo and risperidone, we could not see any difference, and concerning the cognitive function, there was an advantage in the placebo group. And the same year, Horner and colleagues made a similar study, and they said that addition of risperidone doesn't bring about an additional advantage. A year before, on the other hand, Josiasen and colleagues talked about the possible efficacy of this combination, and this was their first presentation. And there was a meta-analysis of all these research studies conducted in the field, And as a result of this meta-analysis, it was said that there wasn't any significant difference than placebo regarding the efficacy of risperidone. Other than risperidone, aripiprazole and amisulpride were tried, and here we see two studies with the addition of aripiprazole, and in one of these studies we see that there is an improvement of negative symptoms, and this was a controlled study published in 2008. With a larger sample group, a second study was conducted, and such an improvement could not be observed in this study, and no difference was found between groups in terms of the change in total positive and negative symptoms. Regarding amisulpride, there is one controlled study in the literature, and in this study, especially when it was added at a dose of 600 milligrams per day, improvement of global functioning, severity of illness, and depressive symptoms were improved. Amisulpride was used, in fact, and was published at the end of 90s and was shown to be advantageous. And if sartrinol was coupled with pimozid, controlled studies showed no benefits, and when two agents were added, an important side effect was the lengthening of the QTc interval on ECG. And ziprasidone was added to the spectrum after 2002, and zinc and Kulski studies are continuation of each other. One was a 6-week study, the other was a 26 and 52-week study, and the risperidone was compared to ziprasidone, and the addition of both were yielding positive effects, and one wasn't superior to the other. However, there were side effects with risperidone, especially extrapyramidal system was affected and hyperprolactinemia developed, and there was QTc lengthening in the other one. And there was another publication that was published in 2014, add-on ziprasidone compared with placebo. Here we see that there's an improvement of cognitive symptoms, especially semantic fluency, that was emphasized. All these studies, at least most of these studies from 1989 to 2011, all the add-on studies, the most recently conducted meta-analysis includes 14 studies, and add-on to other antipsychotics was superior to placebo. However, the size of the effect was small, so this was significant. However, the impact of the effect was small. And contrary to what has been said in other studies, 6 weeks can be regarded as a satisfactory period, and it wasn't necessary to have longer periods of add-on treatment. And in the discussion part of the meta-analysis, this was emphasized. Other than antipsychotics, augmentation can be conducted with mood stabilizers to clozapine. These were investigated with controlled studies. The reason for me to bring these three agents was that they were tried in controlled studies, and the first results were not that positive, and addition of lithium to clozapine did not increase clinical efficacy, however, might result in increased side effects, it was said. Concerning clozapine plus lamotrigine topiramate, and there was decrease in presynaptic glutamatergic release. That was the aim in using lamotrigine as well as topiramate. When lamotrigine was added in controlled studies conducted in 2003 to 2007, there was great hope. And in the first three studies, when we have a look at the data, we see that both the negative and the positive symptoms and the total psychopathology benefited from this addition, as the findings implied. However, in 2007, Goff and colleagues conducted two separate studies which could not show a similar effect, and they said that augmentation was not as shown in the previous studies. In the year 2009, we have a meta-analysis, and we see that 0.57 was the result, and they said that this was an hopeful augmentation alternative. Based on these findings in Hacettepe University, in schizophrenia patients who were clozapine resistant, we performed an augmentation study, and this was published in Schizophrenia Research in 2013. And lamotrigine augmentation in patients with schizophrenia who show partial response to clozapine treatment was the name of the publication. And the effect on the glutamatergic system through utilizing mismatch negativity through an electrophysiological parameter, MMN component. And there was an evaluation which was different than the other studies. This was a 12-week randomized double-blind placebo-controlled prospective phase 3 study. And when we have a look at the past lamotrigine studies, we decided to increase the dose of lamotrigine to 200 milligrams, and at week 6 we were giving this dose to the patients, and the included patients were receiving 150 to 900 milligrams of clozapine during the last year at least, and they were on stable dose in the past month. We paid attention to this, and the severity of the psychopathology was evaluated in this sample group. In the lamotrigine and placebo arms, there were 17 patients. When we have a look at the clinical features of these patients, they did not differ much in terms of gender, education years, total number of hospitalizations, and clozapine use, duration of use. These parameters were not different between the two groups. However, the results were not as anticipated. This is a negative study, and the addition of lamotrigine did not bring about any additional advantage in this controlled study. And when we have a look at the PANSS score, and in fact placebo group at the end of 12 weeks seemed to be better than the lamotrigine group, and the findings were as such. So contrary to what we expected, the results were obtained like this. And we also evaluated the cognitive functions in the study, like attention, verbal memory, verbal fluency, executive functions, working memory, and visuomotor speed. And between the two groups, in terms of these parameters mentioned, we could not find any difference. Mismatch negativity in schizophrenia, we know that this is decreased, and if lamotrigine has an effect on the system, if we would have shown this effect, then mismatch amplitude might have increased. That was our hope. However, we could not find anything as such in the lamotrigine and placebo groups during this period of time. Mismatch amplitude showed decreases in both groups, contrary to what we have expected. However, there was no change between the groups in terms of MMN amplitude and latency. I can dwell upon the details of this if questions are raised. Concerning safety, at the beginning and at the end point, safety parameters were evaluated, and there was no finding pointing out a pharmacological interaction. Clozapine and lamotrigine were within therapeutic range during the study period. In conclusion, similar to the study by Goff and colleagues, no benefit of lamotrigine augmentation was shown in schizophrenia patients with partial response to clozapine. Why was this the case? Because in the previous studies there were positive results. These were the studies by Zoccali and Tilhonen, and maybe they had lower baseline severity of illness, maybe less chronic nature and shorter duration of illness. We concentrated on reasons about this sample group. Another observation, chronic treatment with clozapine already acts on the NMDA-mediated glutamatergic dysfunction, and any further improvement is difficult to obtain. And as observed earlier, this is also true for glycine site agonists when used as add-on. And it has been suggested that elevated glutamate activity in schizophrenia is most marked in the early phases of the illness, especially in the prodromal period. That might be one of the reasons. In the chronic patient group that we selected, even if an effect might have appeared, as a significant period has elapsed, we might not have seen this possible effect. That was one of the discussion points we raised. And in a meta-analysis conducted by including our study into the scope, lamotrigine for positive symptoms, negative symptoms, and overall symptom score did not bring about any positive results compared to placebo, and it wasn't any different than the placebo. Topiramate add-on, and similar to lamotrigine, there were studies that yielded both positive and negative results that were conducted from 2005 to 2011. The meta-analysis of these studies was conducted in 2014, and it is not favoring topiramate, and we see that it is not any advantageous than placebo. Clozapine plus antidepressants. Antidepressants might be added to clozapine, and for some patients there can be positive results obtained on negative symptoms, positive symptoms, and total symptoms. And the results are as follows. In the meta-analysis that was performed, we see that Stelopram as a single study was found significant, and it is as if this is the only study that is positive, so it is not possible to focus on this single study while meta-analysis are there. So what other alternatives are there in terms of pharmacological treatment? There are partial or full agonists of NMDA receptors, and these might be added to typical antipsychotics, and this advantage did not appear when these were added to clozapine. D-serine or cycloserine-like agents or sarcosine, glycine inhibitors did not prove effective. On the contrary, they resulted in somewhat of a worsening. Memantine was added in recent years as a partial agonist, yielding positive results, as we can see. And in this meta-analysis, you see that there is an improvement of total and negative symptoms and a superiority to placebo. Concerning glycine, in a recent meta-analysis, there is worsening in positive symptoms compared to placebo, although a positive effect was anticipated. Other than this, omega-3 fatty acids were added, and there were studies yielding positive, negative, and conflicting results. There is a ginkgo biloba add-on study by Doruk and colleagues from Turkey, and a positive effect on negative symptoms was shown. However, modafinil, donepezil, tetrabenazine controlled study results do not give much hope. Electroconvulsive therapy augmentation of clozapine. The number of controlled studies are very limited in that regard, and the first study I show you here is including 18 patients, and it's the comparison of clozapine and placebo together with electroconvulsive therapy. So this is a small group. In all the three groups we have 3 per week, total of 12 sessions of electroconvulsive treatment therapy. However, the fastest result was in the group that received clozapine plus ECT. This year, Petrides and colleagues published a randomized single-blind control study. 8 weeks of clozapine was compared to 8 weeks of clozapine plus ECT, and the patients who did not respond to a treatment of clozapine after 8 weeks, there was a crossover addition of ECT, and you see the assessment of psychopathologies with different scales, and we see that the response rate is quite high. In objective measurements, a 20% of an improvement is seen sufficient. However, here we see a 40% reduction taken as a marker, and we see that 39 patients were included, and 50% of the patients had response despite this 40% threshold. And we see that if the patients were treated with an additional 8 weeks of ECT, the response rates were up to 50%, and the total response rate is 48.7, meaning that half of the patients have quite high response figures. And concerning the negative symptoms, it does not have any positive impacts, and it doesn't bring about any extra disadvantage as it seems. However, processing speed slows in the clozapine ECT group. However, in other measurements, there wasn't any striking difference. In terms of the side effect profile, prolonged or spontaneous seizures were not observed in any of the patients after this addition. So long-term outcomes of this study, I believe, will be published in the near future by the group, Petridis and colleagues. In our department from 2012 to 2014, there were 17 patients in whom augmentation was tried with clozapine and electroconvulsive therapy. Let me briefly touch upon the findings of this study. Of these 17 patients, most of them were schizophrenia patients. ECT was used for the purpose of augmentation in 77% of these, and the dose was 600 on average. Of these patients, at the end of the ECT period, 75% had improved illness. Of the patients who had improvements, we see that their baseline disease severity was somewhat higher. Most common side effects were agitation, headache, bradycardia, hypertension, and arrhythmia, and there were not any prolonged seizures in these patients. Augmentation of clozapine with transcranial magnetic stimulation. This is something that is tried, and in patients who have cortical instability, we have 2 sham-controlled studies. Despite being reliable, these are not effective, and for clozapine-resistant negative symptoms, we do not have any sham-controlled studies. Another method other than clozapine augmentation, in patients in whom we cannot use clozapine or in patients who do not want to use clozapine, we have other antipsychotics, and combination is an option. And in recent years, high doses of atypical antipsychotics are being used. Let me briefly touch upon this one as well. Use of high-dose atypical antipsychotics like risperidone, quetiapine, ziprasidone, aripiprazole, and olanzapine. We see that most numerous studies were conducted with olanzapine, and there are 3 controlled studies, and in the study by Volavka, we see that doses about 30 milligrams were used and yielded results similar to clozapine. In the study by Conley, clozapine was superior to high doses of olanzapine olanzapine, and 2 studies showed us that these were effective. In recent years, Meltzer and colleagues conducted a study with high-dose risperidone. Here they used 50 milligrams and 100 milligrams bi-weekly, and after the end of 6 months the effects were evaluated. At the end of this period there wasn't any difference in terms of the response. In fact, what was anticipated is that olanzapine would be superior. However, they could not receive any such result. However, minimal extrapyramidal effects were there, and the medication was well tolerated. Long-term studies have to be conducted, was the conclusion from this study. Atypicals and combinations of these, there are open studies, case reports and series. However, controlled studies are not found in this area. You see the combinations here, and the most commonly used ones are these. Regarding the addition of aripiprazole, there is a warning. If atypical antipsychotics are to be used, these might be increasing psychosis in the early periods of the treatment. It is said that's why there is a warning in that regard, which has to be highlighted. And when we have a look at this study, other than not having controlled studies, we see that the indications are mixed. For certain patients there is resistance to treatment, and in the others the combination is used for the purpose of reducing the side effects. The indications are mixed. That's why it is hard to interpret this study. And criteria for treatment resistance was not well defined. In conclusion, if I am to summarize, we have gone beyond claustrophobia, and if we tried clozapine, what can we do further? If we are to consider augmentation first, as regards the addition of antipsychotics, we see that it is not consistent, the results. However, in certain patients it might be positive, and effects on psychopathology other than positive symptoms can be there, like negative symptoms, depression, and additions with AREP, AMIS, and ZIP might have positive effects. And when we have a look at the partial agonists of the NMDA receptors or AMPA modulators, we might see beneficial effects with memantine and ampakine, and most promising augmentation strategy appears to be ECT, with at least 50% of a response, which cannot be which should be taken into consideration. Maybe we should be more courageous in that regard. What should be the next step if clozapine is not sufficient? Evidence involving high-dose atypical antipsychotics is limited but present, and evidence involving the efficacy of combining atypical antipsychotics other than clozapine is still insufficient. Thank you very much for your patience.